start by thanking everybody for joining us today for our MVC component of the Blue Cross P4P program year 26 and 27 explainer webinar. My name is Mark Bradshaw. I'm MVC's Managing Director, and I'll be getting the ball rolling on this today. Before we go full steam ahead, just a quick disclaimer that this session is going to be recorded. It'll be shared with you all after the meeting. And as part of this, as we're going through the discussion, I think we're in Zoom webinar format. So if you have any questions, please submit them to the chat, and we'll have plenty of opportunity throughout to dive into those. Okay. So at our recent collaborative-wide meeting, which I hope some of you were able to attend, we shared the changes to the MVC component that will be taking effect in program year 26 and 27. And since then, you should have all received your selection reports via Dropbox to assist you in making your choices for the next cycle. So today's webinar is not designed to dig down deep into your individual selection reports in a lot of detail, but instead the aim today is to summarize the changes that are being made, provide a walkthrough of how the program will be scored in light of these changes, and ultimately to discuss what the next few weeks look like regarding selection submission. So as part of this, we'll provide a good picture of how MVC and our coordinating centre team can support you as you work to determine those selections. And like I said earlier, we'll leave plenty of times for Q&A in case you have specific questions that have come up, either from the collaborative-wide meeting, today's discussion, or in reviewing your selection reports. Okay, as we weave through this agenda, I'll be joined by a couple of my MVC colleagues, including MVC Senior Analyst Julia Mantey, who leads our MVC P4P program, and our Engagement Manager, Jessica Souva. Okay, so if you've been part of MVC's P4P program over the years, you'll have seen this slide a number of times. It's our P4P guiding principles. And these principles really just underpin the development, the implementation, and the continued refinement of our program. And they were really kept top of mind when we were looking to cement each of the changes for program year 26 and 27 that we're touching on today. In particular, I just want to call out our aim is really to ensure that the MVC program remains fair, simple, and transparent for our participants. You know, that second entry we see in that list of core principles there. So as I mentioned, the changes that we're sharing today are for 26 and 27. They are not being put in place for your current program cycle of 24 and 25. If you were at the collaborative-wide meeting and you heard this spiel already, you might have asked the question then, why are we talking about this now? If you're fresh to this today, you might have the same question. Why are we talking about this now when 26 and 27 seem so far away? This timeline slide helps answer that question. The structure of the MVC component means that program year 26 is actually based on performance data from 2025. So in our mind, that means if you're truly going to implement new practices or initiatives or build on ones that you already have in place to improve performance in the areas that you select, then you need to be afforded the opportunity to choose before the end of 2024. So it's for that reason that the changes were launched at the collaborative meeting. It's for that reason your program year 26 and 27 selection reports have been shared with each of you for completion by December 13th. So as we look to the future, the structure of the P4P program within MVC for program year 26 and 27 is going to remain largely the same. There are a few tweaks, though, that I'll call out and walk through in a little bit more detail. The first change of note is the addition of a new health equity measure that will be worth 1 point. And there'll be more to come on this in today's presentation. With this addition, because we're allocating 1 point to that, we'll be removing 1 point from our episode spending metric, meaning a total of 3 points can now be earned in that area. Our value metrics will remain at 4 points, and our engagement activities, our menu of engagement activities that you'll be familiar with from this year, will continue to be worth a maximum of 2 points. So let's take a closer look at these as we step through. That's the structure. There are some changes within that structure that I just want to call out and go through. It will be repeating a lot of the information that perhaps you heard at our collaborative-wide meeting, but like I said, just to reiterate and help fill in the gaps for those that weren't able to attend. We're breaking our changes down into 4 categories, and those are payer mix, our episode spending condition menu, value metric alignment, and our health equity measure. Each of these changes in developing and getting them through started at January 2024, and we've worked throughout the year to get them through there. They were reviewed and approved by both MVC's advisory committee and a couple of times with the Blue Cross Hospital P4P quarterly work group. I mentioned a number of times already that these changes have been communicated to the collaborative already. Today will be a shortened version of that. If you're interested in a bit more detail, I'm happy to sit down with folks and go through that in more detail. The slides from our October semi-annual are also available on our website if you'd like to take a look at those online. Okay, so I'm going to step through each of those categories that I just put on the screen: the payer mix, the episode spending condition menu, the value metric alignment, and the health equity measure. So if we start with our P4P payer mix, as time has progressed, we've spent a great deal of time at the coordinating centre trying to ensure that the MVC component is truly representative of all the patient populations that MVC serves. So what that's meant is that we've added additional payers over the years as and when new data sources have become available in-house. In our current structure, the MVC programme, so if we think about programme year 24 and 25, that includes data from Blue Cross PPO, Blue Cross MA, BCN HMO, BCN MA, and Medicare fee-for-service. One of the biggest wins for the coordinating centre, because of the time it took to get it over the line, has been the addition of Michigan Medicaid to our data portfolio, which we did in the last 24 months or so. And that takes us up to that 84% of covered lives with MVC's data portfolio, with that addition of around 1.8 million covered lives through the Michigan Medicaid data. And as we continue that trend of making sure that the P4P program truly represents the diverse patient populations that participants serve, we've made the decision to add Medicaid into our payer mix for 26 and 27. When we proposed this with the work group and we talked it through with our advisory committee, we got a couple of questions, what plans fall under this umbrella, what sub-payers fall under this umbrella. MVC has data for all Medicaid beneficiaries across the state, and as a result, in adding Medicaid to our P4P program, all sub-payers will be included under this umbrella. Also, in discussing this addition with our advisory committee and in discussing it with the Blue Cross P4P work group, the importance of ensuring that members have access to this new data source was not lost, and it was stressed time and time again. We've been working, and hopefully you've seen it over the last couple of years, to familiarise the collaborative with this new data source. We've ensured that Medicaid data is readily available on our registry. It's included in our push reports now that you each receive through Dropbox on a monthly basis, and it's also available as part of our custom analytic offering if you took part of those in recent months. In addition to these support opportunities, Medicaid data is also reflected in the baseline measures provided in your 26 and 27 selection reports. So each of those mechanisms have been put in place as a way of trying to increase member familiarity and comfort with MVC's Medicaid data, but we always, across the board, welcome additional ideas from membership on how we can best support you navigating this change. So if it is a new area, especially within MVC, and you're interested in learning more, please just get in touch with the collaborative and we'll do our best to step you through that. Okay. So that's Medicaid data. Maybe I'll pause just to see if there's any questions in the chat that have come through so far, specifically related to the Medicaid aspect. I can't quite see the chat, so if someone on the MVC team could maybe unmute and let me know if there is any questions, and I'll do my best to answer them.
Nothing's come through yet, Mark. Okay,
great. All right, on to episode spending condition menu. So there's a few things to call out here. For program year 24 and 25, you'll see the selections on the left there. When we look at 26 and 27, we're going to be removing 3 conditions which have historically been offered on MVC's episode spending condition menu. And those conditions are colectomy, pneumonia, and joint replacement. The reasoning behind those, we gave a little bit of detail when we presented this at the collaborative wide meeting. To give you the shortened version, nobody actually selected colectomy for program year 24 and 25. So limited collaborative interest, we decided it was a no-brainer to remove that from our episode spending condition menu. Pneumonia was also not no selections. I think we had 5 or 6 selections for that condition. And again, it was viewed to have limited collaborative interest. Joint replacement was a little bit different in the sense that this has been a real success for the collaborative. It's been part of MVC's P4P program since inception in 2018. And over time, we've seen it deliver what it was intended to do. As well as that, with the shifts in site of care for joint replacement and the limited variation which we're seeing remaining in the post-acute care space, we took the decision to remove joint replacement as a condition option for 26 and 27. With that brings the opportunity to consider new condition candidates. And we did an extensive internal review of all of our existing conditions. We have around 43 within MVC just now. And walking through those, discussing with our partners on the work group, discussing with other CQIs, we identified PCI as a new menu option. And that will be on your selection reports if you're eligible for it for program year 26 and 27. So with all of this taken into account, you'll see that our episode condition menu will move from having those 6 options to 4 for program year 26 and 27. And in case you want another visual for this, here's it spelled out on the screen. The episode spending condition menu for 26 and 27 will be CABG, CHF, COPD, and PCI, as highlighted in your recent selection report. Just to call out as well, to be eligible for one of these 4 spending conditions, you must have had at least 20 cases in the baseline year of 2023. So if you got your selection report and you only see 2 of these, that'll be why you don't have the sufficient number of cases to be eligible for the other 2. So our episode spending scoring methodology is remaining the same as in previous years, with sites still receiving the better of their improvement and achievement scores. In this respect, we class improvement as being based on a hospital's past performance, whereas achievement speaks to performance in comparison to the designated MVC cohort. The only difference that I do want to call out here that I mentioned at the start of our discussion today is that the episode spending metric will be worth 3 points as opposed to 4 points in previous years. So on to our volumetric alignment. Again, before I proceed with this, just a quick check if we have any questions on the episode condition spending portion and the changes which are being put through for 26 and 27.
Nothing yet, Mark.
Okay, thank you, Emily. On our volumetric alignment, and this is an important one which we've been doing over the years, and we did it again this time around. And that is making sure that our menu aligns with what other CQIs are doing. Through our site visits, through our P4P one-on-one discussions, through conversations with our advisory committee, we've heard pretty clearly that aligning MVC's P4P program with other CQI initiatives would be extremely useful, both in terms of reducing the resource burden that are placed on sites, but also in helping doubling down on related QI activity. And, we hear you. And with this in mind, we've made a small change, but an important one to our existing sepsis value metric. So if you look at 24 and 25, our MVC sepsis value metrics focus on 30-day risk-adjusted readmissions after sepsis. And when we met with HMS, who does a lot of work in the sepsis space, and discussed with their leadership team, we determined that a more aligned metric moving forward was going to be a 14-day follow-up after sepsis value metric, not only to support MVC's continued efforts in this area, but also to contribute to HMS's sepsis initiative, for which increasing post-discharge care coordination is a core and central aim. So that's the one change to the volumetric menu, which you may well have seen in your selection reports, moving from that 30-day risk-adjusted readmissions after sepsis metric to now a 14-day follow-up after sepsis value metric. And with this change, members still have the ability to choose one value metric from a list of 7 different options. Again, just to call out, to be eligible for any of these value metrics, your hospital has to have at least 20 cases in the baseline year 2023. So again, if you received your selection report and you're only seeing 3 or 4 of these 7 on there, it's because you're not eligible for the other conditions, the other value metrics, I should say, that are on the menu. And as with our episode spending measure, our value metric scoring follows the same methodology as the current cycle, meaning hospitals are evaluated against their own performance and against their cohort, and they'll receive the higher of the 2 for a maximum of 4 points. So while episode spending is 3 points, remember that value metrics are worth 4 points for program year 26 and 27. Okay, so if I bring that all together and sum it up, program year 26 and 27 is going to see the addition of Michigan Medicaid data in our payer mix for the first time. In addition, we are retiring colectomy, joint, and pneumonia from the episode spending condition menu, and PCI will be added as a new option. Elsewhere, I walked us through the fact that our sepsis value metric is going to change to a 14-day follow-up measure to ensure that alignment with HMS. And with all these changes, we designed the selection reports in a way to provide a variety of supporting data to help inform your choices, which are due on that December 13th date. If it would be helpful to walk through those selection reports in a one-on-one meeting with your site, then please remember there is the option to sit down with the MVC Coordinating Centre to do exactly that. We have some open dates between, I believe it's the November 25th and the December 6th, which you can grab one of those, and Julia, our senior analyst, and a couple other folks from the MVC team will walk through those selection reports and help you interpret them for the most effective choice. Okay, now moving on to the health equity measure. And when I presented on the Medicaid piece, I called out that adding that into our payer mix brings us much closer to reflecting the diverse patient populations that our members and our P4P participants serve. In addition to this, we're going to also introduce a new claims-based health equity measure for 26 and 27. And this P4P health equity measure really aims to address some of the barriers that we've heard from members that they find preventing continued improvement efforts in this area. We surveyed the full collaborative, and what we heard was it's often hard to push improvement efforts due to a lack of data, no clear business case, or maybe a lack of financial investment. So with our new measure, we're hoping that we're able to provide members with consistent hospital level equity data. We're also able to demonstrate those equity gaps. And the added bonus, because it is worth a point and because it is tied to P4P dollars, perhaps offering up a financial incentive to invest in equity related initiatives at your sites. And before I walk through this in more detail, I do just want to emphasize that this measure is different from the episode condition and value metrics that I previously walked through. It's not an option for selection. So you're not looking at a menu and saying, hey, I want to pick this for my health equity measure. It is a specific measure that all sites will be evaluated against. So when you've received your selection reports, you'll see your supporting data for your episode spending condition menu, for your value metrics. There is also in your Dropbox some information in the health equity measure, but as I said, it is not a selection there. It will be a measure that all sites will be evaluated on for that one point. So the measure in detail, we're going to be quantifying and tracking differences in all-cause readmissions between payers at each of our participating sites by calculating what we call an index of disparity. And this measure indicates essentially the extent of differences which exist in payer-specific, risk-adjusted all-cause readmissions within a hospital. So if you think about that, a lower index of disparity, a lower IOD indicates a smaller spread of readmission rates across payer groups. Our risk-adjusted all-cause readmissions will be calculated for hospital overall and for 5 specific payer groups. And that's Blue Cross and BCN commercial together, Blue Cross, BCN, Medicare Advantage together, Medicare fee-for-service, Medicaid, and dual eligibles. And we understand this is a new measure, and that's why we're easing it in, and we're only tying one point to start with it. And we've tried to structure scoring to methodologies that has been similar to how we've structured episode spending and value metrics in the past. So with that in mind, hospitals will have the opportunity to earn the one health equity P4P point via 2 pathways, and those are improvement achievement, which hopefully sounds familiar. To earn the point via improvement, hospitals need to just decrease their index disparity by at least 10% in the performance year compared to baseline. And then alternatively, hospitals can earn the point through an achievement by having an IOD, an index of disparity, at or below the collaborative wide median. So we've set the kind of threshold there, somewhat specifically at right in the median, because again, this is a new measure. We want to ease it in. That may well change over the years, but at least to start, we're starting with a low starting point in terms of that 10% improvement or at or below the collaborative wide median. So hopefully there's plenty of opportunity for sites to really earn that extra point. So I mentioned we're easing it in with 1 point tied to it. The other way we're going to get the collaborative hopefully familiar with this measure and have plenty of opportunity for back and forth and questions is to introduce it into our program year 25 scorecards. So this measure is not in effect till 26 and 27, but we're going to start reporting it in your 25 scorecards for informational purposes only. And the aim of that is just to help sites become familiar with it. And like I said, open that forum for questions throughout the year until we get to the point where it's formally live in 26 and 27. So to reiterate, no points attached to this in program year 25, but we are going to report on it just to help you get familiar with the measure. In that sense, we're going to try and provide reports which show specifically the hospital and the payer level risk adjusted readmission rates that have been used to calculate that index of disparity. And that really gives you the actionable information to highlight areas of opportunity which you can tweak, you can target to really impact that IOD and have that feed through to your relevant score with one eye on earning that point. To help demonstrate how this measure, as well as our episode spending condition, our value metrics ultimately are going to work in practice, we're going to take a look at some scoring examples. Again, before we dive into those scoring examples, which may help answer some questions that you have top of mind, let me just pause in case there's any questions in the chat relevant to our episode spending metrics, our value metrics, health equity measure, any of the other changes that I discussed so far today. Do we have any questions in the chat?
Nothing so far, Mark.
Okay. All right. With that, then let's take a look at some scoring examples. And for this, I'm going to pass over to MVC senior analyst Julia Mantey. I mentioned at the start, she does a lot of work leading our P4P program. So when you receive reports, whether it be selection or scorecards, Julia's been leading the charge on that with support from one of our other analysts, Kushbu. And she's going to step us through some scoring examples. So Julia, I hope you're on the line and you're able to unmute and take us through the next few slides.
Yep.
Perfect.
Great. So we'll take an example hospital. We're going to call it Hospital A through these examples. These may look familiar because, as Mark mentioned in the previous slides, the methods for scoring episode spending and value metrics have not changed really. So first, walking through this example, Hospital A chose to be evaluated on CHF as their episode spending condition and cardiac rehab following a CABG procedure as their value metric. So we'll see how their scoring will work. So first, looking at the episode spending condition, again, they chose CHF. So for this, we're going to calculate 4 numbers. First, the hospital's performance year payment, and then the hospital's baseline year payment, which we'll use to evaluate improvement compared to the hospital. The cohort's baseline year payment, which we'll use to evaluate achievement, and then the standard deviation across all MVC hospitals. So those numbers you can see are 17,800 for the hospital performance year. The hospital's baseline year payment was higher than that at 18,158, whereas the cohort's baseline year payment was lower than that at 17,240, and then the MVC all standard deviation was a little over 3,000. So this is the equation we use. You can see the equation is the same for both improvement and achievement. The difference is what we use as the comparison. So when we're looking at improvement, we're taking the difference between the hospital's baseline and the hospital's performance year, dividing that by the MVC all standard deviation. So plugging in those numbers, the result that we get is 0.12. When we look at achievement, we're comparing to the cohort. So instead of subtracting the hospital performance from the hospital baseline, we subtract the hospital performance year payment from the cohort's baseline year payment. And then again, divide that by the MVC all standard deviation. And in this case, that result is negative 0.18. And then we plug that into our scoring matrix. So we have these breakpoints for what that Z-score, it's what we call that final number, equates to. If it's less than 0, 0 points are awarded. If it's 0 to less than 0.1, 1 point's awarded. In this case, the improvement Z-score of 0.12 falls between 0.1 and less than 0.2. So hospital A earns 2 improvement points, whereas the achievement Z-score was less than 0. So they earned 0 achievement points. And again, we take the better of the 2. So hospital A, for their episode spending condition for this performance year, would earn 2 points. When we look at value metrics, we again calculate 4 numbers: the hospital's performance year rate, the hospital's baseline year rate, the cohort's baseline year rate, which is used for achievement, and then the MVC all standard deviation. Again, hospital A in this example is looking at cardiac rehab after a CABG procedure. So we can see those numbers are 65.6% is the hospital's performance year rate. The hospital's baseline year rate is lower than that, 51.5%, and the cohort's baseline year rate is also lower than that, 58.5%. So we can see, just looking at this, that hospital A is doing better in the performance year compared to both themselves and to the cohort. And then the MVC all standard deviation is 13.7%. When we plug those numbers in, first, our improvement Z-score, we'll look at hospital performance minus hospital baseline, because here the intention is to increase the rate. So we order those numbers so that a positive score is what we're looking for. That results in 1.029 for the improvement Z-score. And then we calculate the achievement Z-score. We're comparing hospital performance minus cohort baseline, and that Z-score is 0.518. And then once again, we have a point matrix, so you can see where each of those Z-scores fall in the matrix. So the improvement Z-score of 1.029, that will exceed 0.75. So for improvement, hospital A has earned 4 improvement points, whereas achievement 0.518, that's going to fall in that 0.5 to less than 0.75 bracket. So that'll equate to 3 achievement points. We take the better of the 2, and hospital A earns 4 points for their value metric. Now, go in a little bit more detail for the new health equity measure. This is again worth 1 point. Mark was explaining that to calculate the index of disparity, which we refer to as the IOD, we take the readmission rate at the hospital. So it's calculated separately for each hospital. So the readmission rate overall at the hospital, and then each payer-specific readmission rate. So you can see in this graph, we're looking at hospital A, the overall all payers green dot, a little over 15%, call it 16% is their readmission rate. And then you can see there's a separate dot for each payer, and you might notice that the dots are slightly different sizes. That's because the formula for the calculation weights each risk-adjusted readmission rate by the proportion of that population in the hospital. So if you have a very small population for one payer, and that population's individual readmission rate is very high, that won't massively influence your resulting IOD. And I would just also add, while we're here, that all of these examples, the IOD as well as the value metric and episode spending calculations, are in our P4P technical document. So if you ever want to look back to see the math that's going on under the hood, we've got it there too. And we're also happy to walk you through it. So again, as Mark said, just like with our other measures, a hospital can earn a point through achievement or through improvement. So first we'll look at this example of how hospital A might have earned the health equity point through achievement. Hospitals can succeed in achievement by having an IOD in the performance year that's equal to or lower than the collaborative-wide median IOD. So for this particular route to earn the point, we won't be looking at the baseline year IOD. We'll just look at the performance year. We take the median of all hospitals' IODs and then compare each hospitals to that median. So if the median across all hospitals in this performance year is 2.0 and hospital A has an IOD of 1.96, which is what would be the result from the reflected rates and populations in this example, they would earn that point through achievement. Then a hospital can also earn the point through improvement. So that is done by decreasing the IOD from the baseline year to the performance year by 10%. And that's 10% of the baseline year score. So in this case, each of these 3 years is hospital A. So in 2024, the baseline year, their IOD was 2.38. That means that in order to earn the point via achievement, they'd need to reduce their IOD by 10% of 2.38, which is, let's call it 0.24, but 0.238. So in this case, they have that IOD of 2.38 in the baseline year, and you can see the individual payer readmission rates kind of gravitate a little bit more toward the overall rate within each year. So those margins of differences start to decrease. So in 2025, which is that mid-year where you're not scored, the IOD is 2.04. And then in 2026, the performance year, it was 1.56. And 1.56 is a reduction from 2.38 of 0.86, which was well above the 0.24 that would have been needed. So they would achieve that improvement point.
Great. Thank you, Julia. And thank you everybody on the webinar as well for staying with us through all of these slides. We do, like Julia said, we think it's important to lift the hood, get in the weeds, and walk through exactly how we score each of those sections of the MVC component, especially as you're gearing up for your selections for 26 and 27. As Julia said, we're sharing all of that information and how scoring works in kind of 10-ish minutes. But there's a ton of work that's gone into it that is available in our technical documents that we're available to walk through in more detail. So if you like being in the weeds, then we do too. So let us know and we can step that through with you at a separate time. We're going to change gears slightly now and focus in on basically what the next couple of weeks look like in terms of selection process. And Jessica, I'm going to hand over to you for that. So can you just step us through what's gone on so far and what's to come, RE selections for 26 and 27?
Yeah, I also noticed that there was a question, but I think Julia is answering the question on the IOD measure, looking at the collaborative-wide versus the cohort for comparison. If there are others that were wondering that, you should be able to see that in the Q&A section. So for the selection process, you'll have the overview of your condition selections in your Dropbox. You should be able to get into your Dropbox. If you haven't had success with that, please let us know and we can definitely help walk you through how to get into Dropbox and see your selection reports. And in certain circumstances, we can also email those if we're not able to get you into that. I know there's different issues with firewalls and things like that, so do not fret. We will definitely make sure that you get your reports. If you want to go on to the next slide, after you've had an opportunity to look at your selection reports, review those with your teams, and have made a decision about what value metric and what condition for episode spending you would like to select for PY 26 and 27, you'll submit those via Qualtrics form. QR code is here. You will get this in numerous emails that will go out over the next couple of weeks as reminders. And as resources to follow up with us if you wanted to do one of those one-on-one meetings before submitting this, or if you need to just walk through it with us at a separate time. Yeah. Thank you. So we've been talking quite a bit about PY 26 and 27. I'm going to switch gears just a little bit and remind folks that with the engagement points, you're earning points for the year that you're actually in. And so we're switching over to PY 25. We thought this would be a good opportunity to just talk through some of the changes that you'll see in PY 25, even though this webinar was mainly about 26 and 27. So one of the primary things that you will notice is we are asking that folks submit contact updates. In the beginning of 2025 in January, we're going to be sending out everyone a list of who we have for your site. We're trying to make sure that our messages aren't just floating out there in the ether and nobody's really getting the right information to the right people. So we'll ask that you send us a response back by February 14th so that we can have a successful 2025 together in all of our events and activities. Then the other major thing that you'll notice when we go into the next slide is going to be that there's increased opportunities and flexibility for both member presentations and work group participation. Thanks. This might be a little small for folks to see, but I'll just kind of highlight the main changes that are happening in 2025, in addition to us asking you to complete those contact updates. Another thing that you will see here is that instead of having all of the presentations broken down into different subcategories, we've kind of grouped those together, and we will be sending out calls for presentations for our various events and activities. And those will be opportunities to present for virtual work groups, networking events, posters, roundtables, or breakout sessions at our collaborative-wide meetings. So lots of opportunities to folks to share best practices with one another in different events and venues. And then another major change that you'll see, it's not super major, but one thing that we recognize is that in-person activities are a bit more of a lift for folks to be able to attend. So we are giving a little bit more credit for in-person networking events as opposed to virtual networking events. And then probably one of the most popular things that we've heard from folks that we've talked to about this so far are the changes to the way the work groups are set up in 2025. So in 2024, if you recall, you had to attend all 4 of a series. We do still have the same topics: cardiac rehab, pre-op testing, all of those things that we had in 2024. However, you will be able to earn points for each work group that you attend. You don't have to attend the entire series to get any points at all. And with that, the opportunity for earning points in work groups is increased slightly as well. You can earn a maximum of 1 full point in 2025 from work group attendance. And if we go into the next slide, this just thought I'd give a little bit of an example, since we looked at scoring examples for the episode spending and the value metrics. So opportunity to get 1 full point is shown here in the work groups. The 3 cardiac rehab work groups, as well as some health and action work groups. And then with the fall and spring collaborative wide meeting, that would earn another 0.75, and then a virtual site visit to get the full 2 points. If we go into the next slide, this just gives you, and this is on our website as well, but this just gives you a look at the dates that we have set up for our virtual work groups in 2025 and our collaborative wide meetings in 2025. So you'll see that May 9th, we will be in Midland again. And then on October 10th, we will be in Livonia for our fall collaborative wide meeting.
Thank you, Jessica. So with that, and I think we are getting right towards time as well, can we just open it up for any questions that the attendees might have on anything we've talked about today? First check, Emily, maybe you can let me know if there's any questions in the chat, and then we can just see if any more flurry in before we wrap up. Is there any in there, Emily?
Nothing in the chat. We've actually got 2 different places where questions can be put in right now. So nothing in the chat, but I did just see that Mantey sent in a question. Is this menu for PY 2026 and PY 2027? I think that was in reference to Jessica's presentation of the engagement menu. So this is the menu for 2025, Mantey.
We, for 2026 and 2027, there may be some slight tweaks to it. We like to be responsive to what we hear from our members throughout the year. So we'll see how 2025 goes with this menu, and then towards the end of 2025, based on the feedback that we get from members, we may make some slight tweaks.
Thank you. Any other questions? No? Okay. At the risk of sounding like a broken record, but I'm going to sound like a broken record, your selections are due on the 13th of December. We've lengthened the selection window this time round in response to feedback. If you've been picking these selections for a while now, you remember we actually only used to have a 2-week window. And we heard, not enough time to consult everybody in the organization that needs to be at the table for these, especially if folks are in and out. We're also cognizant that the fact that Thanksgiving is coming up next weekend, and that wipes out a good few days for folks. So selections are due December 13th. Please make sure they're in by that date. We have had in past years participants miss the boat, and that's obviously something that we want to avoid. So if anything, get that marked on the calendar, December 13th. But in the meantime, we're here to help with walkthroughs of the selection reports, or anything else that you want to bounce around before you lock in those selections. But with that, we appreciate everybody's time today. We'll be sending out the materials following the meeting. I mentioned the recording as well. But like I said, any questions, don't hesitate to get in touch. The email's on the screen. All right, thanks everybody.